A warm welcome for Professor Sheffer.
Thanks. Great. Well, thank you very much, Dr. George, for letting me be here at this KCNQ2 Cure Summit. I have to say I came once previously in 2018, which was the beginning of our sleep study that I'll talk about at the end. And I think I've done 3 online, and I hate speaking into that black box. So it's really nice to be here and to be with you all and to meet the families again, and of course the scientists. I'm in a bit of a KCNQ2 world because I was in Naples too. So I'm immersed in potassium channels. So here are some of my very special bears with children and adults, I shouldn't say bears, with KCNQ2. And here are my disclosures. So I thought I'd start with a bit of context because we've had now 2 days of KCNQ2, gain of function, loss of function, this syndrome, that syndrome, and it is very confusing and very complex. And just to reinforce that KCNQ2 diseases cause both mild outcome epilepsies and severe outcome epilepsies. And if we think about the mild outcome, that's the self-limited neonatal epilepsy, which was discovered through through families, but it's not always familial. But we also have the KCNQ2 encephalopathies. And I think, particularly for everyone in the room, that is really the urgent area, the huge unmet need. And when we talk about encephalopathies, one of the areas I've done a lot of work in is called the developmental and epileptic encephalopathies, which are these very severe epilepsies with a lot of epileptic activity affecting development. But we now know through a paper from Mary and now Sarah and many others too, that we can have KCNQ2 intellectual disability, which was the same as developmental encephalopathy without epilepsy. We also know that we are sort of splitting very neatly into gain and loss of function phenotypes or presentations. So John Millichap led the story with the infantile epileptic spasm syndrome, which is always a developmental and epileptic encephalopathy. Sarah Mulkey wrote a paper about profound intellectual impairment with non-epileptic myoclonus and central hypoventilation. And then, of course, this very important area that we've just heard about intellectual disability, where children have that and often autism, but no epilepsy. But then we have the loss of function KCNQ2's encephalopathies. And the loss of function ones are much better known because I was fortunate to be involved with Sarah with the original publication on this back in 2012 of the early infantile DEE, which is often profound. And that also overlaps with the syndrome of epilepsy of infancy with migrating focal seizures. And then just to put that into its broader context, the self-limited forms, as we've heard physiologically, are loss of function as well. But that really is the whole picture of the epilepsies and the encephalopathies. And if you're confused, you can see why. It is complicated. So I just thought I'd spend a couple of slides on some new data. One is around the epidemiology of KCNQ2. This first study at Scotland looked at all seizures beginning under 3 years of age and found where they found a clear monogenic cause, single gene cause. It had a frequency of 1 in 2,120. And you can see here from this Scottish data that KCNQ2 was number 3 on the list. They had 10 patients with it, and 2 of them had the DEE, and 8 of them had the self-limited form. But importantly, that gave us a number. KCNQ2 epilepsy was responsible for 1 in 17,000 live births. Then one of my PhD students, Catherine Howell, did an epidemiological study of severe epilepsies with onset under 18 months in Victoria, Australia, and we found a 1 in 2,000 frequency. But importantly, this did not include Dravet syndrome, so that was a problem with the structure, but we got 2.6% of this 1 in 2,000 were KCNQ2. And then just recently with my New Zealand PhD student together with Lynette Sadlier, we've done an epidemiological study of the Wellington region of New Zealand. And this is looking at all severe epilepsies with onset under 16 years of age. And to most people's surprise, we found that 1 in 590 children have a developmental and epileptic encephalopathy. That's far more than people have recognised. And 1 in 800 children have intellectual disability with epilepsy. So the DEEs are more frequent than the intellectual disability children and epilepsy. And just to drill down on this data, which is currently unpublished, we had in this cohort of GEMMAs, we had 235 children. Only 53 had a genetic diagnosis. They did not have a full hand of genetic testing. But of those 53, 3 had KCNQ2, 2 had a developmental and epileptic encephalopathy, and both had de novo variants, which means new in that child, and 1 had intellectual disability and epilepsy and had an inherited variant. And the bit at the bottom is the important bit in red, which is this cumulative incidence, which has not been shown before for KCNQ2 epilepsy, severe epilepsies, not the mild end, of around 3 per 100,000 children. And interestingly, came out the same as Dravet in this study. But if you took all the SCN1As, because there's gain of function as well, it was higher. So we think of KCNQ2 as a lot rarer, but it's not a lot rarer. All right, so I've been charged with talking about comorbidities, and these children with all the developmental and epileptic encephalopathies have a host of comorbidities. They are not just seizures. We have to treat the whole child and try and improve the outcome on all these issues. In addition to seizures, we have developmental issues, behavioural problems, psychiatric problems such as autism spectrum disorder, gait issues, gut issues. I'm going to leave the gut issues for the next speaker, sleep issues and movement disorders, and a host more, but these are the most frequent. So I wanted to touch on movement disorders and just talk to you about a recent study that we have coming out actually this week online in neurology about movement disorders in patients with developmental and epileptic encephalopathies. And this was led by a very talented Dutch medical MD PhD student called Sterre van der Veen. And in this study, I noticed that movement disorders were much more frequent than most people have recognised in the developmental and epileptic encephalopathies. And it's very important as a clinician and as a parent to differentiate this, because you have to figure out, are they epileptic or non-epileptic movements, and they have different management. They may need medication. If it's epileptic, obviously anti-seizure medicines, but if it's a movement disorder, they may need medications or other strategies. And by that, I mean things like deep brain stimulation. So I'm just going to give this to you in a nutshell, but this was a study of 77 patients. Now, they were ascertained because they had a known gene causing their developmental and epileptic encephalopathy, and we observed a movement disorder. So it's not a percentage of patients, it was because they had a movement disorder. What sort of movement disorder do they have, and does it correlate with the biology? And you can see here that in these 77 patients, the median onset of the movement disorder was 18 months. The median onset of the seizures was 4 months. So the movement disorder was quite a bit later. Stereotypies were the most frequent, and they are the ones I'm going to show you in the KCNQ2 children. Dystonia was next, and a range of other movement disorders. And we found that it's hard to see under there, but 47% had more than one movement disorder, so 50% had a single movement disorder. And you can see here that chorea and dystonia were quite common, and then other types of movement disorders. And some had just paroxysmal, which means intermittent, not all the time. So here are the KCNQ2 children, and this little guy's here, and he's 5 years older than when I saw him last time. Thank you very much to his parents. And he's having stereotypies, which are consistent movements that are always the same. They're involuntary, and you can see that with his rocking movements. And then the next little guy has some as well, but they're much more subtle. And so there you can see his stereotypies. And then you can see he's got some very little stereotypies that you can see, but there are also these very constant movements. And on the right, we have Jackie. And Jackie has got a tic disorder, which is sort of on the spectrum of stereotypies, and it's quite severe and it's making her walk backwards, but it's also those unusual leg movements that she has. So in fact, KCNQ2 DEE was the most frequent one to be associated with movement disorder, with this stereotypies. And here you see another video of Jackie with this tic disorder where she's bending her leg, which is making it quite precarious to walk. But she can still jump and interact and be Jackie, thankfully. And then other movement disorders described in KCNQ2 are myokymia, and there are also episodes of hyperkinetic movement disorders with fever, with chorea and myoclonus. So movement disorders are generally under-recognised in patients with developmental and epileptic encephalopathies, and that's because we're so focused on the epilepsy that nobody's really noticing that. It's important to differentiate, and I, as an epileptologist, often need to bring them into hospital and do video EEG monitoring to sort it out once and for all, and you can get it wrong. Smartphones are fantastic. I ask parents to get me 3 examples of anything so that I can have a look at the context, at the triggers, and at the features similar. And we need a lot more larger cohorts to understand which genes cause which movement disorders. So we found some ideas in the paper around correlations. And then this is one of the things we'll need to manage when we get to tailored treatment. Now, this is actually a Dravet patient, but one of the mothers yesterday said that her child, who was late adolescent, I can't see if she's here actually, had a scoliosis. And this is a scoliosis. I haven't seen that in my KCNQ2 patients, but it can come on quite suddenly with puberty, with the pubertal growth spurt. And you can see this Dravet patient at 18 years, and he had to wait for his surgery till COVID allowed him to get into the hospital, and you can see the difference it can make. So this is another type of musculoskeletal problem you can have. All right, I thought I'd spend a moment talking about seizures, and I'm not going to spend too long on that, but just to talk about seizure patterns changing with age. And this is from one of Sarah Weckhausen's papers, which looked at seizure types at different ages. And you can see here that under 1 year of age in blue, tonic seizures are the most frequent, which is what we see in the newborns, as many of the families know. And then from 1 to 18 years, the pattern changes more to red tonic-clonic seizures, but then the adults develop a pattern with a lot of focal impaired awareness seizures. The better news for KCNQ2 DEE is that quite a lot of patients leave their seizures behind. And here you can see from this same study, it's only 2 patients, so it's not large numbers, but you can see that quite a lot of patients have grown out of it by adult life, but some remain with seizures. And I just wanted to showcase another study we've just recently published this year with a pediatric registrar, where we looked at different genetic DEEs and said, is status epilepticus, which is where a seizure goes for 30 minutes, is that more common in some genetic DEEs than others? And what about the mortality rate and the risk of sudden unexpected death in epilepsy? And here we looked at 510 patients with a known genetic DEE, and we used in the cohort, we had to have at least 10 patients in each group to include them, because we wanted to have enough of a number to get a feeling for how frequent, or some data for how frequent seizure types were. And I've coloured in yellow here Q2 to show you that we had 28 KCNQ2 patients. And in this rather busy slide, I'll just highlight KCNQ2, and you can see in purple convulsive status epilepticus occurred in about 20% of KCNQ2 patients, and you can see non-convulsive status epilepticus occurred in only about 5 to 10%. So in some ways that looks a bit better. And if we look at our mortality data, which was about 8% of patients had died by the time of the study, we had nobody with KCNQ2, but then yesterday's table in the parent session said a different story with some very sad losses. So I don't think KCNQ2 is safe, but it's, I guess, better than some of the other ones in terms of the risk of sudden unexpected death in epilepsy. All right, so let's turn to development. And here I've broken it down into what do the loss of function patients look like. And generally, they have a very severe outcome. They're non-verbal, they don't walk, they have this axial hypotonia, which means your trunk is weak, and spastic quadriplegia, as you can see in this little girl and this little boy, and they remain dependent for daily care. In the adults, we see over 50% have severe intellectual disability, 15% have profound impairment. This is a very important issue, and that is psychiatric issues. And we have autism in a lot of patients, but we also can have behavioural problems that are very severe with aggression and self-injury and anxiety, and only a very small number have no psychiatric issues. Now, what about the gain of function? I'm not going to tell you about Luca because you heard about Luca from the boss, but basically now we're getting much more understanding of this gain of function encephalopathy, still far fewer cases than with the loss of function phenotypes, but they have mild to severe intellectual disability, and as you heard, Luca is really very severe. Many of them have significant autistic features, hypotonia, and around 40% have epilepsy beginning in childhood or infancy, but not neonatal. And they also have this pattern of sleep activation. And this is a beautiful study from Sarah and Ed's group. And they basically compared the R144 pathogenic variants. They had 3 different flavors, a Q and a W and another one. And they had enough to compare the Q versus the W. And they showed very clearly that the R144Q is more severe, with them all having severe intellectual disability, whereas the W was mild to severe. If you have a look at behaviour, it was more severe as well in the Qs, but the Ws are very autistic. And then if you have a look here, the seizure pattern is much better for the R144Ws who had no epilepsy in general. So this was an elegant genotype phenotype study, and again, no neonatal seizures. So the last part of my talk is on our sleep study, which is being led by Annie Chu, who is a pediatric neurologist from Hong Kong, who has come to work with me. And now she's been so inspired by this project. She's just enrolled in a PhD on sleep and DEEs, thanks to you. And this really came from 2018 when I attended the conference in Boston, and thank you to the parents who've participated, and especially the ones who've participated while I've been here. And we use this sleep disturbances scale for children, which looks at 6 different areas of sleep: difficulty in initiating and maintaining sleep, sleep breathing disorder, disorders of arousal, sleep-wake transition disorders, disorders of excessive somnolence, and sleep hyperhidrosis. We had 28 patients, but 42 questionnaires, because a number of you have used the COVID pandemic. So we've got a second questionnaire 4 years later. 40% had ongoing seizures, and a third had ongoing nocturnal seizures, which of course is important for sleep. And I'm going to just bring you to the important bit. 71% had abnormal score in at least one category, and over half an abnormal total score. And I know some of your children sleep really well, but many do not. And here you see the pattern. Most commonly is this colour, the blue, which is difficulty in initiating and maintaining sleep. So watch this space with your data that you've given me here, and hopefully over the next few weeks, we'll be able to get much better results and data. So in conclusion, I've really just had a moment to highlight these many comorbidities that children with and adults with KCNQ2 encephalopathies have. And we've got to realise that if we're looking for precision medicines, we need to treat all of them, not just seizures. I'd like to close by acknowledging families, because I think you're the most important drivers of all of this, and particularly to acknowledge the wonderful Sarah, who's taken me on her long journey with her. And we've weathered lots of medical storms together, but we're here, and Jackie's doing well, and that's a wonderful thing. I'd like to thank my own research team, which you can see here is fantastic, my wonderful international collaborators, and particularly acknowledge Sarah and Maurizio. And finally, thank you again.
Thank you so much. You're a pro in every way, including being perfectly on time. That was amazing. So much there with those comorbidities. We do have a couple of minutes for questions if anybody has one. I'm going to start off because I do have one with the movement disorders, which are such a striking feature of a number of different DEEs. What research is being done into potential medicines that might trigger them? Because I know in our case that Jackie had those shocking ones that you helped us get through, and there was a bit of medicine correlation. So how is that? I mean, she would be, I'm assuming, far more likely than a typical person with a typical brain. How do you tease out all of these factors as the smart scientist that you are?
Thank you for the impossible question. Basically,
I specialize in those.
It's an interesting question. Did she get exacerbation or much worsening of that tic disorder because of the drug she was on? Clearly they melted away when she stopped the drugs. So there was clearly a correlation. But as a clinician, I think it's really important to manage the most difficult problem at the time. That's all you can do. And she was put on the risperidone and then the aripiprazole because of very severe agitation and aggression, self-injury. She got nasty, very severe laceration. And so at the time we had no choice, and the psychiatrist treats the behavior, not me, but we had no choice but to get her onto those. And then this overwhelming tic disorder started, and it stopped with stopping the drug. Now, is that a KCNQ2 brain? I don't know that. I guess I'm a bit nervous about it, but I'm also, at the time, she needed the other drugs to survive and for everyone around her to survive.
Absolutely.
So, you really have to, the clinical balancing is doing what's best for the patient and their family at that time.
I totally, by the way, agree with every bit of this. These disorders are really complicated. Al, yes?
Not that I'm not loud enough, but wonderful talk. In terms of managing some of these comorbidities, and I'm going to ask you about sleep, are there medication solutions that are not harmful? Or do they hypnotic, Ambien and things like that? Do they help or do they hurt in general?
Oh, look, I think there are plenty of things you can do with medication, and we're collecting that data as well. The most common thing and the easiest thing is melatonin. And lots of the families use melatonin. There are different forms of melatonin, so just beware that when I prescribe melatonin, it's different to what you buy at the drugstore. It's much better melatonin that's prescribed. So not all melatonins are equal, like not all CBDs are equal. And so that's the first thing. Clonidine can be helpful, and then other drugs can help, and the anti-epileptics can be helpful as well for sleep. So we definitely need to work on sleep, because you have a sleep-deprived child, you have a very sleep-deprived family.
And Brian, you've got a question?
Question here, but also research. We've been filling out every possible study and doing every possible survey, and I noticed, of course, that lots of the surveys are asking about behavior, and I can pick up that they're asking about autism as one of the comorbidities. I can tell you that my child hasn't ever exhibited any signs that would point toward autism. But as I check out all of these different questions, do they say please and thank you? No, she doesn't talk. Do they interact with people in a meaningful way? No, she's developmentally disabled. How do you, as you and other researchers, tease out that difference between developmental disorder and autism? I guess
No, that's a really good question. And I think it's particularly hard in these DEEs. So somebody earlier today had a slide up and they said the patient had profound impairment and autism. It's not possible. If you have profound impairment and you don't walk and you don't talk, how can you know they have autism? So that's not showing the understanding of the severity. But when you have severe intellectual disability, you can very easily see if the child's got autism, because are they social? You can be nonverbal and smile and look at you and come and give you a cuddle, or you can be nonverbal and not know there's a human in the room looking down all the time, and do plenty of severe intellectually disabled patients will just do a repetitive behavior. That goes with severe intellectual disability, but they're not all autistic. So it's a world apart, and it's about understanding their behaviors.
I think we've got time for one more question. Yes, I'll bring the mic over to you.
Autism, at what age do you think
Well, I think that's where Danuta's comments were incredibly powerful because she recognised it at 8 months or maybe even sooner in her little one. But
He's a boy.
yeah, well, adult women are often missed too. But I think that we generally you can see it from quite a young age, and by that I mean by 1 easily. I think I don't know that people will be confident to make a diagnosis, but you can see it in a 1-year-old who's very autistic. But there is a third of people with autism have autistic regression, and that occurs at around 18 months to 2 years. So they can look fine until that point and then regress. So it's very important to see a developmental pediatrician or an autism psychologist or a neurologist that will be able to pick the difference. But it's usually pretty obvious, to be honest.
All right. Thank you very much. Big